This recorded lecture will be going over Unit 2 in the PN Mental Health Nursing ATI textbook. This will be covering chapters 7 through 10. Chapter 7, Psychoanalysis, Psychotherapy, and Behavioral Therapies. Psychoanalysis, psychotherapy, and behavioral therapies are all approaches to addressing mental health issues using various methods and theoretical bases. Nurses working in mental health settings need to be familiar with these methods as they're part of approaches in their application and practice. Psychoanalysis. Classic psychoanalysis is a therapeutic process of assessing the unconscious thoughts and feelings and then resolving conflict by talking to a psychoanalyst. These patients will attend many sessions over the course of months to years. Due to the length of psychoanalytic therapy and health insurance constraints, classic psychoanalysis is unlikely to be the only choice of therapy. Past relationships can be a common focus for therapy to uncover any unconscious conflicts. Transference is the feelings that a patient has developed towards a therapist in relation to similar feelings towards significant people in their early adulthood. And then countertransference, that unconscious feeling that the healthcare worker has towards the patient. The client can remind them of a person from their past in a positive or a negative manner. We have therapeutic tools, such as free association. This is the spontaneous, uncensored verbalization of whatever comes to the patient's mind. Dream analysis and interpretation. This is believed by Freud to be urges and impulses of the unconscious mind that played throughout the dreams of patients. Then we have the use of defense mechanisms. These can help decrease or prevent anxiety by blocking awareness of negative feelings. Psychotherapy involves a more verbal therapist-to-client interaction than classic psychoanalysis does. In this situation, the patient and therapist will develop a trusting relationship to explore the patient's problems, and this can take 20 or more sessions. Psychodynamic psychotherapy will employ the same tools as psychoanalysis, but focus more on the patient's present state rather than in their early life. There's interpersonal psychotherapy. This will assist clients in addressing specific problems. The goal of this therapy is to improve interpersonal and social functioning, which will reduce the psychiatric manifestations. There's cognitive therapy. This is based on the cognitive model, which focuses on the individual thoughts and behaviors to solve current problems. This can treat depression, anxiety, eating disorders, and other issues that can improve by changing a patient's attitude toward their life experiences. We have behavioral therapy. Behavioral therapy is based on the theory that behavior is learned and it does have consequences. Abnormal behavior will result from an attempt to avoid painful feelings. Changing abnormal or maladaptive behavior can occur without the need for insight into the underlying cause of that behavior. Behavioral therapies to teach patients ways to decrease anxiety or avoidant behavior and give clients an opportunity to practice their techniques. Behavioral therapy can teach activities to help the client reduce any anxious and avoidant behavior, like relaxation training and modeling. Behavioral therapy can be used successfully to treat patients with phobias, substance use, or addictive disorders, as well as other issues. Then there's cognitive behavioral therapy. This is going to use both cognitive and behavioral approaches to assist a patient with anxiety management. This therapy will take into account what the patient thinks influences their feelings and behaviors. Then we have dialectical behavior therapy. This is a cognitive behavioral therapy for patients who have a personality disorder and exhibit self-injurious behavior. This type of therapy will focus on gradual behavior changes and provide acceptance and validation for these patients. So how do we use our cognitive therapy? Well, we can use cognitive reframing. Cognitive reframing will assist the patient to identify negative thoughts that produce anxiety, then examine the cause and develop some supporting ideas that can replace their negative self-talk. Through this type of therapy, the patient can change their thinking to realize that they may have made bad choices, but that doesn't mean they're a bad person. There's priority restructuring. This can assist the patient to identify what requires a priority. Journal keeping will help a patient write down any stressful thoughts and can have a positive effect on their well-being. Assertiveness training will teach a patient to express their own feelings and solve problems in a non-aggressive manner. And monitoring thoughts will help a patient be aware of any negative thinking that they're doing. There are types and uses of behavioral therapy, such as modeling. Modeling can occur in an acute care milieu to help patients improve their interpersonal skills. Operant conditioning. The patient should receive positive rewards for positive behavior, reinforcement. Systematic desensitization. This therapy is the planned, progressive, or graduated exposure to anxiety-provoking stimuli in real-life situations, or by imagining events that cause anxiety. During the exposure, the patient would use relaxation techniques to suppress any anxiety response. Systematic desensitization should begin with the patient mastering their relaxation techniques. Then the patient is exposed to increasing levels of their anxiety-producing stimulus and uses their relaxation to overcome their anxiety. In aversion therapy, you would pair a maladaptive behavior with a punishment or unpleasant stimuli to promote a change in that behavior. In a mental health setting, a therapist or treatment team can use an unpleasant stimuli, such as a bitter taste or a mild electric shock, as a punishment for behaviors, such as alcohol use disorder, violence, self-mutilation, and thumb sucking. There's meditation, guided imagery, diaphragmatic breathing, muscle relaxation, and biofeedback. All of these tools are various techniques that you can use to control pain, tension, and anxiety. Other techniques include flooding. This is exposing a patient while in the company of a therapist to a great deal of an undesirable stimulus in the attempt to turn off the anxiety response. There's response prevention. This is preventing a client from performing a compulsive behavior with the intent that the anxiety would diminish. There's thought stopping. Teaching a patient whenever negative thoughts or compulsive behaviors start to arise, they need to say or shout stop and substitute a positive thought. The goal would be that over time, the patient would use that command silently. And validation therapy. This is useful for patients with a neurocognitive disorder. It's a process of communication with a disoriented older adult patient that respects and validates their feelings in a time and place that's real to them, even though it's not actual reality. Chapter 8, Group and Family Therapy. Therapy is an intensive treatment. It involves open therapeutic communication with participants who are willing to take part in the therapy. Although individual therapy is a very important treatment for mental illness, group and family therapies are also a part of the treatment plan for many patients in a mental health setting. Examples of group therapy include stress management, substance use disorders, medication education, understanding mental illness, and a dual diagnosis group. A group process is the verbal and nonverbal communication that occurs during group sessions. This would include how the work progresses and how the members interact with one another. A group norm is the way the group behaves during behavior sessions, and over time will provide structure for the group. For example, a group norm could be that members will raise their hand to be recognized by the leader before speaking. A hidden agenda. Some group members or the leader may have goals different from the stated group goals that can disrupt a group process. For example, 3 members might try to embarrass another member who they dislike. A subgroup is a small number of people within a larger group who will function separately from that group. Groups can be open, which means that new members join as old members leave, or they can be closed, which means that no new members join after the formation of the group. The dynamics of a group are affected by the group being either open or closed. A homogeneous group is one which all members share a certain chosen characteristics, such as a diagnosis or a gender. Membership of a heterogeneous group is not based on a shared chosen personal characteristic. An example of a heterogeneous group is all clients on a unit, including a mixture of males and females with a wide range of diagnoses. There are different components of therapy sessions. We need to use open and clear communication. There are cohesiveness and guidelines for the therapy session. There is direction towards a particular goal. There is communication regarding respect among all members. There is a focus and goals for the individual, family, and group therapies. For individual therapy, the focus is on the client needs and their problems, as well as the therapeutic relationship between the provider and patient. The goal of individual therapy is to make more positive individual decisions, to make productive life decisions, and develop a strong sense of self. For family therapy, the focus is on the family needs and the problems within those family dynamics. The focus is on improving family functioning. Goals of family therapy include learning effective ways to deal with mental illness within a family, improving understanding of the mental illness among family members, and maximizing positive interaction among all family members. In group therapy, the focus is on helping individuals develop a more functional and satisfying relations within a group setting. Goals of group therapy can vary depending on the type of group, but generally, patients should be able to discover that members share some common feelings, experiences, and thoughts with each other, and they should experience positive behavior changes as a result of their group interaction and feedback. Group therapy goals also include diminishing any feelings of isolation and providing a more cost-effective environment than that of individual therapy. We have different age groups in group therapy. For children, group therapy can occur in the form of play while talking about a common experience. For adolescents, group therapy can be especially valuable, as this group will typically have strong peer relationships. And for the older adult, group therapy can help with socialization and sharing of memories. There are, of course, phases of group development. In the orientation phase, the primary focus is to define the purpose and goals of the group. The responsibilities, including setting a tone of respect, trust, and confidentiality among members, and there is always a discussion about termination. In the working phase of the group, the primary focus is to promote problem-solving skills to facilitate behavioral changes. Power and control issues can dominate in this phase. Responsibilities of this phase include cohesiveness to be established, and the role of the leader should be gradually diminishing. In the termination phase, the primary focus is to mark the end of the group sessions. Responsibilities would include group members discussing their termination issues and eliciting feedback regarding the group therapy. There are certain roles within a group. Maintenance roles. Members who take on these roles would tend to help maintain the purpose and process of the group. For example, a harmonizer would attempt to prevent conflict. There are task roles, in which members take on various tasks within the group process. An example would be the recorder, who would note and record what occurs during each session. And individual roles. These roles will tend to prevent teamwork, because individuals will take on roles to promote their own agenda. An example would include the dominator, who tries to control other members, and the recognition seeker, who boasts about their own personal achievements. Group characteristics can vary depending on the healthcare setting. In an acute mental health setting, members can vary on a daily basis, and the focus of the group is on relief. These unit activities will directly impact the group, and the leader needs to provide a higher level of structure. In an outpatient setting, these members are often consistent. The focus of the group is growth. External influences are limited, and the leader can allow members an opportunity to determine the group's direction. Let's look at some different types of families. A nuclear family includes children with their married parents, who reside with their married parents. A single-parent family would include children who live with a single adult that can be related or non-related to those children. An adoptive family would include children who live with parents who have adopted them. A blended family includes children who live with one biological or adoptive parent and a non-related step-parent who is married. Cohabitating families include children who live with one biological parent and a non-related adult who are cohabitating. Extended families include children living with one biological or adoptive parent and a related adult who is not their parent, grandparent, aunt, or uncle. Other families would include children living with related or non-related adults who are neither biological nor adoptive parents, such as grandparents, adult siblings, or foster parents. Family is the first system to which a person is attached, and it is the most influential system to which an individual will belong. Families go through various developmental stages. The roles in the family members will fulfill change throughout these changes. Families can have healthy or dysfunctional characteristics in one or more areas of functioning. So let's look at some areas of functioning. Communication. In a dysfunctional family, one or more members would use unhealthy communication patterns, which would include blaming, manipulating, placating, distracting, and generalizing. Management. In a healthy family, adults of a family will agree on important issues, such as rulemaking, finances, and plans for the future. In a dysfunctional family, management can be chaotic, with a child making management decisions at times. Boundaries. In a healthy family, boundaries are distinguishable between family roles. In a dysfunctional family, you can have enmeshed boundaries. This means that thoughts, roles, and feelings will blend so much that individual roles are now unclear. Or you can have rigid boundaries. This is when rules and roles are completely inflexible. These members often do not share thoughts or feelings. Then there's socialization. In a healthy family, all members would interact, plan, and adopt healthy ways of coping. In a dysfunctional family, children do not learn healthy socialization skills within their family, and then have difficulty adapting to socialization roles in society. And emotional and supportive. In a healthy family, conflict and anger do not dominate the situation. In a dysfunctional family, negative emotions will predominate most of the time. These members are isolated and afraid and will not show concern for each other. Additional concepts related to family dysfunction include scapegoating, triangulation, and multi-generational issues. Multi-generational issues can also include patterns of substance abuse, addictive behavior, dysfunctional grief patterns, triangulation patterns, and divorce. Discipline. Family behavior that can be healthy or dysfunctional is the action of disciplining. Setting limits on a child's behavior will protect their safety and provide them with security. Disciplining should be consistent, timely, and age appropriate. Parents should administer discipline in private when they are calm. Caregivers should be in unison on how and when to discipline. A family is defined as a group with a reciprocal relationship in which members are committed to each other. Areas of functioning for families include management, boundaries, communication, emotional support, and socialization. Dysfunction can occur in any one or more areas. In family therapy, the focus is on the family as a system rather than on each person as an individual. Chapter 9, Stress Management. Stress is the brain's natural response to any demand. Stressors are physical or psychological factors that produce stress. Any stressor, whether perceived as good or bad, will produce a biological response in the body. Anxiety and anger are damaging stressors that cause distress. The body responds to a perceived or actual threat by activating the fight or flight response. If stress is prolonged, maladaptive responses can occur. The patient who manages stress in a healthy manner is a flexible individual and uses a variety of coping techniques or mechanisms. Responses to stress and anxiety are affected by factors such as age, gender, culture, life experiences, and lifestyle. The effects of stressors are cumulative. Data collection for a patient in stress. Protective factors will increase a patient's resilience or their ability to resist the effects of stress. This would include their physical health, a strong sense of self, religious or spiritual beliefs, optimism, hobbies and outside interests, satisfying interpersonal relationships, strong social support systems, and humor. Some expected findings with stress. A patient experiencing acute stress in the fight or flight situation would experience apprehension, unhappiness, or sorrow, decreased appetite, increased respiratory rate, heart rate, cardiac output, and blood pressure, increased metabolism and glucose use, and a depressed immune system. A patient in a prolonged state of stress experiencing a maladaptive response would experience chronic anxiety or panic attacks, depression, chronic pain, and sleep disturbances, weight gain or loss, increased risk of myocardial infarction and stroke, poor diabetes control, hypertension, fatigue, irritability, and decreased ability to concentrate, and they are at an increased risk of infection. There are some standardized screening tools that we can use, such as life-changing events questionnaires to measure life-changing units, the perceived stress scale, and Lazarus's cognitive appraisal. When providing patient-centered care to our patients dealing with stress, most nursing care will involve reinforcing teaching of stress reduction strategies to our patients. Some cognitive techniques include cognitive reframing. This is when the patient is helped to look at any irrational cognitions or thoughts in a more realistic light and to then restructure those thoughts in a more positive way. There are some behavioral techniques we can use. Meditation can help a patient connect with their deep inner self and also promote healing and strategies to cope with stress. Guided imagery. The patient is guided through a series of images to promote relaxation, and these images can vary depending on the individual. We know that breathing exercises can be used to decrease rapid breathing and promote relaxation. Progressive muscle relaxation can be used to achieve a relaxation response. This technique would involve purposefully tensing specific muscle groups and then relaxing them in a progressive format. Progressive muscle relaxation is an easy technique that can be performed almost anywhere. Physical exercise such as yoga, walking, and biking will cause a release of endorphins that lower anxiety, promote relaxation, and have antidepressant effects. Use your nursing judgment to determine the appropriateness of relaxation techniques for patients experiencing acute manifestations of a psychotic disorder. Journal writing is another technique. It has been shown to allow for the therapeutic release of stress. Journaling can ease anxiety, worry, and obsessional thinking. It can also increase one's confidence and hope. This activity can help the patient identify any stressors and then make a specific plan to decrease those stressors. Cognitive reframing is the patient learning to prioritize differently in order to reduce the numbers of stressors affecting them. Biofeedback will use a sensitive mechanical device to assist the patient to gain voluntary control of autonomic functions such as their heart rate and blood pressure. Exercise gadgets like smartwatches can provide the ability to track sleep and heart rates. Mindfulness. The patient should be encouraged to be mindful of their surroundings and use all of their senses. They need to learn to restructure negative thoughts and interpretations in positive ones. Assertiveness training. The patient should learn to communicate in a more assertive manner in order to decrease any psychological stressors. For example, one technique teaches the patient to assert their feelings by describing a situation or behavior that causes stress, discussing feelings about that behavior or situation, and then making a change. The patient states, "When you keep telling me what to do, I feel angry and frustrated. I need to try making some of my own decisions." There are, of course, other individual stress reduction techniques, and these would include individual hobbies such as fishing or scrapbooking, music therapy, pet therapy, sleep, massage, and aerobic exercise. Chapter 10, Brain Stimulation Therapies. Brain stimulation therapies offer a non-pharmacological treatment option for patients with certain mental health disorders. Brain stimulation therapies include electroconvulsive therapy, or ECT, transcranial magnetic stimulation, or TMS, and vagus nerve stimulation, or VNS. Electroconvulsive therapy uses an electrical current to induce brief seizure activity while the patient is anesthetized. The exact mechanism of ECT is still unknown. ECT is indicated for major depressive disorder. These would be patients whose manifestations are not responding to pharmacological treatment. These patients are suicidal or homicidal, and there is a need for a rapid therapeutic response. Or it can be used for patients experiencing psychotic manifestations. ECT is indicated for schizophrenia spectrum disorders. This would be patients with schizophrenia with catatonic manifestations, and for patients with schizoaffective disorder. ECT is also indicated for acute manic episodes. These would be patients with bipolar disorder with rapid cycling, which means 4 or more episodes of acute mania within 1 year, as well as for patients who are unresponsive to treatment with lithium and antipsychotic medications. Some contraindications to ECT. There are no absolute contraindications. However, medical conditions can place the patient at a higher risk of adverse effects. These conditions include cardiovascular and cerebrovascular disorders. Some mental health conditions for which ECT has been not found very effective include substance use disorders, personality disorders, and dysphoric disorders. Some considerations for the nurse providing or monitoring a patient in ECT. The typical course of ECT treatment is 2 to 3 times a week for a total of 6 to 12 treatments for depression. A pre-ECT workup would include a chest X-ray, blood work, and EKG. Benzodiazepines should be discontinued as they would interfere with the seizure process. Then the medication management of the actual procedure. 30 minutes prior to beginning the procedure, the patient will receive an IM injection of atropine sulfate. This is administered to decrease any secretions that could cause aspiration and also to counteract any vagal stimulation effects. At the time of the procedure, an anesthesia provider will administer a shot of short-acting anesthetic, typically etomidate or propofol, via IV bolus. Then a muscle relaxant such as succinylcholine is administered to paralyze the patient's muscles during the seizure activity. That can decrease the risk of injury. Succinylcholine will paralyze the respiratory muscles so that the patient requires assistance with breathing and oxygenation. Severe hypertension should be controlled because a short period of hypertension will occur immediately after the ECT procedure. It's the nurse's responsibility to monitor vital signs and mental status before and after the ECT procedure. Many patients and families have misconceptions about ECT due to media portrayals of the procedure. Due to the use of anesthesia and muscle relaxants, the tonic-clonic seizure activity associated with the procedure in the past is no longer an effect of the treatment. An IV line is inserted and maintained until full recovery. The patient receives 100% oxygen during and after ECT until the return of spontaneous respirations. Ongoing cardiac monitoring is provided, including blood pressure, EKG, and oxygen saturation. And patients are expected to become alert about 15 minutes after ECT. Some complications of ECT include memory loss and confusion. Short-term memory loss, confusion, and disorientation will occur immediately following the procedure, and this can persist for several hours. Whether ECT causes permanent memory loss is controversial, but most patients will fully recover from any memory deficits. As nurses, we need to provide frequent orientation, provide a safe environment to prevent any injury, and assist the patient with personal hygiene as needed. Another complication includes reaction to anesthesia. As nurses, we need to provide continuous monitoring during the procedure and, of course, in the immediate recovery phase. Another complication includes cardiovascular changes. As nurses, we need to monitor their vital signs and their cardiac rhythm regularly, per protocol. Another complication includes relapse of depression. ECT is not a permanent cure. Weekly or monthly maintenance ECT can decrease the incidence of relapse. Then there's transcranial magnetic stimulation. TMS is a non-invasive therapy that uses magnetic pulsations through MRI strength to stimulate the cerebral cortex of the brain. This is indicated for the treatment of major depressive disorder for patients who are not responsive to pharmacological treatment. TMS is similar to ECT, but it doesn't induce any seizure activity. Some considerations for a patient undergoing TMS include to reinforce the teaching to the patient about the TMS. TMS is commonly prescribed 3 to 5 days a week for a period of 4 to 6 weeks. It can be performed as an outpatient procedure. This TMS procedure will last 30 to 40 minutes. A non-invasive electromagnet is placed on the patient's scalp. This allows magnetic pulsations to pass through. The patient is alert during this procedure. The patients can feel a tapping or knocking sensation in the head, scalp and skin contraction, and a tightening of the jaw muscles during the procedure. Some complications of TMS include a mild discomfort and tingling sensation, as well as headaches. It's important to monitor for lightheadedness after the procedure. Seizures are a rare but potential complication. TMS is contraindicated for patients with a cochlear implant, brain stimulator, or medication pumps because the metal in the device can interfere with treatment. Then there's vagus nerve stimulation. VNS provides electrical stimulation through the vagus nerve to the brain through a device that is surgically implanted under the skin on the client's chest, similar to a pacemaker device. VNS is believed to result in an increased level of neurotransmitters and enhances the actions of antidepressant medications. VNS is indicated for depression that is resistant to pharmacological treatment and/or ECT. This treatment is approved by the FDA. Current research is determining the effectiveness for VNS in patients with anxiety disorders, obesity, and pain. Some considerations for a nurse observing a patient with vagal nerve stimulation include reinforcing the teaching with the patient about VNS. VNS is commonly performed as an outpatient surgical procedure. The VNS device delivers around-the-clock programmed pulsations, usually every 5 minutes for a duration of 30 seconds. Therapeutic antidepressant effects will usually take several weeks to achieve. The patient can turn off the VNS device at any time by placing a special external magnet over the site of the implant. Some complications of VNS include voice changes due to the proximity of the implanted lead on the vagus nerve to the larynx and the pharynx. Other potential adverse effects include hoarseness, throat or neck pain, and coughing. These would commonly improve with time. Dyspnea, especially with physical exertion, is also possible.